Okay, are we ready for me to do introductions? Welcome back to the scientific session of the uh, CCTS and in our virtual format for this time around. So I'm going to introduce two clinicians who have some great experiences with telemedicine. And given our all things tele and the fact that I'm a nurse, we want to look to some of the people who have been out there using telehealth for a while. So Dr. Alice Teal is assistant professor in clinical nursing at the Ohio State University and serves as the director of both the graduate academic wellness program, telehealth services, and at the College of Nursing. She's a member of the Ohio State Academy of Teaching, is a fellow of the American Academy of Nurse Practitioners, and as an integrative nurse coach and nurse practitioner with more than experience, her clinical area of interest include adolescent and college health, primary care of at-risk youth and families, and recovery from substance use disorder. In her current roles with the College of Nursing, she has been integrating the development of wellness partnerships as part of clinical practice for students involved as clinicians in response to the pandemic, including the incorporation of telemedicine. And Dr. Kathy Reinhardt is a primary care family nurse practitioner at Ohio State, specializing in primary care, disease prevention, and chronic disease management. And she enjoys teaching patients on how to get involved with their care. And her favorite part about working at OSU is being a member of interprofessional teams. She uses telemedicine extensively in her practice as well. And if I've left something off or have anything incorrect, please update us on your introduction. Apologies.
Well, thank you for that, Carolyn. I'm happy to be speaking with you today about the use of telehealth clinically, and also known as, or how I frame it, as delivering care from anywhere to everywhere, which is like not an overreach at all, right? Anyway, I'm Alice Teal. I'm going to share with you during this presentation some of my experiences. From the perspective as a nurse educator who's implemented telehealth across the curriculum, and as a nurse practitioner who's used telehealth technologies to deliver care. So our plan in this presentation, I'm going to talk about rationale for telehealth, strategies, barriers for using telehealth, some of the current initiatives that we are implementing at the College of Nursing, and then at the end of the presentation, Dr. Candy Reinhardt is going to provide an update about the care being provided using telehealth at Total Health and Wellness. Okay, so I'm going to begin with defining terms, and some of this might be things that you already know, but I just want to make sure we're all on the same page with this. Telemedicine is focused on the provision of care management using telehealth technologies or using technologies. Telehealth is very broad. The HRSA definition of telehealth is on your screen. It's important to understand that telehealth includes both the synchronous video visits and the asynchronous e-visits, in addition to smartphone applications and video conferencing, online consultations, patient monitoring, either through biometric devices or through other devices remotely. Telehealth also broadly covers the wireless transmission of medical information and communication through patient portals. There's a difference. I mean, we do a lot of teaching our students about the difference between a virtual video visit and virtual care. Telehealth and virtual care are often used interchangeably, but basically telehealth is the way that we are delivering virtual care. All right, so from the Health and Human Services definition, you can see on your screen, we're talking broadly about live video or virtual visits, store and forward technology, especially those used by teledermatology and teleophthalmology, remote patient monitoring. A lot of times we're using this in home health, mHealth, which involves wearable technologies, and then provider to provider consults. The example, I think the basic example being Project Echo. Since 2003, Project ECHO has linked 70,000 learners in 650 programs across 40 countries. Now, when I'm teaching students about this, I think, there's such an expansion and of what we do in terms of addressing urgent problems, episodic or chronic problems, wellness visits. I mean, at some point, right, we talk about when we're talking with individuals and empowering them to use telehealth and connect with us by telehealth, I think at some point we're just going to be saying, come in, click in, log in, however you want to have access. And we are currently across the Med Center, across the College of Nursing. Obviously, for those of you in clinical practice, you already know this. We're using lots of different platforms and lots of different ways to allow people access to us as providers. I'm going to share this with you. I really like this framework for understanding telehealth terminology. This is from a white paper published by the Agency for Healthcare Research and Quality in May of 2020. And in that paper, they were reviewing the evidence base of telehealth. It's called Reassurance in the Face of Rapid Expansion During the COVID-19 Pandemic. And you can see in their framework how the understanding of telemedicine, telehealth, and e-health have evolved and kind of where all those terms fit. I mean, the evidence does continue to show the significant contribution of telehealth regarding improving access to care. I mean, telehealth is not new. It especially true in the delivery of behavioral health and mental health care. I mean, one of the first specialties to expand care by telehealth, showing improvement in access to care, was with behavioral or mental health. So prior to the pandemic, telehealth care and management showed similar or improved outcomes for individuals with diabetes, hypertension, heart failure, respiratory disorders, and mental health disorders. And it showed that it would reduce wait time and improve access to care and correlated to patient satisfaction. I just think about this. I mean, much of the change related to telehealth, even prior to the pandemic, was consumer-led. It was related to consumer demand. There was a study just published looking at how many healthcare apps there are. There are 46,360 healthcare apps as of June 2020. And so I just think about the tsunami of all of the artificial intelligence powered chatbots, check-ins. I mean, there's no surprise to us that the theme of your workshop today is all things tele. Now, certainly prior to the pandemic, the drivers of change were primarily the aging population and the need for chronic care management. I mean, there still is that need. We need coordinated care and access to services for the 84 million individuals who live in the 7,000 plus health shortage areas. Telehealth can improve access to care, and it can help us with addressing barriers. That's what we're seeing, including geographic and transportation barriers that are associated with poor outcomes. 70% of providers, though, in 2017 were using some type of telehealth. The biggest barrier to expansion of telehealth prior to the pandemic was reimbursement. So obviously that was the tipping point. The pandemic allowed for that change in policy related to reimbursement of telehealth services. The 1135 waiver for the public health emergency was again signed in January, and it extends all the way through April of 2021. And what that waiver allows for is reimbursement for telehealth, the same as in-person visits at the same rate. And so the other part of that waiver says that co-pays can be reimbursed or waived for telehealth Um, and we're talking about visits paid for by federal healthcare programs. So I guess the question I pose to you all as you're thinking through this today, and it's what we think of as clinicians as well, is there really any way to turn back now that the genie is out of the bottle, right? And do consumers really want to wait for an appointment to access care, or should they? I mean, some of the things we've learned there are definitely things that we see, people that we see, issues that we can deal with more effectively by telehealth. So the use of telehealth, the other stat that I think is just so interesting, within the first few months of the pandemic, the use of telehealth increased 7,000%. So it certainly has had a significant impact in primary care, chronic care management, specialty care, and in clinical practice. I mean, the question now has really changed from why use telehealth to why not provide care virtually. Okay, so some of this background may have been totally things that you know and understand. Some of it may be things that you have experienced in your own practice. I mean, there's so many questions that I have that I ask myself as an educator, like, so how do we prepare students for a transformed healthcare system? Are we really ready to deliver care from anywhere to everywhere? Like, what are the boundaries of that? What do we need to know? And I know that we all want quality care to remain the same, that we want to meet standards and of practice, even as how we collaborate and how we connect has changed. So for our undergraduate students, we're looking at empowering them to practice at the top of their scope and license. And we're hoping to teach them the skills of telepresenting. For our graduate health science students, we're asking them to learn about what they can and cannot do in terms of delivering evidence-based practice using telehealth. And then we're trying to keep in mind that for the College of Nursing, many of our students are also practicing clinicians even as they are students during this pandemic. So the integration of telehealth in the curriculum at Ohio State College of Nursing, that's also not new. We really began about a decade ago with implementing or including telehealth in our programs. So the top pictures on these slides are pictures of our undergraduate and graduate students learning the skills of telehealth in both the classroom and in clinical settings, or in virtual clinical settings. We often have had our students bring a patient to the webcam, a recruited patient, not a real patient. And we've often used standardized patients, so when they log in, they can do clinical exams or objective structured clinical exams using virtual patients. So this sort of immersive experiential approach where we have included this in parts of the curriculum, and we include it in how we assess and evaluate our students, that we were actually shortlisted for the International Reimagine Education Award in 2018. So about 5 years ago then, the college was gifted telehealth stations to use in our educational programs and with the provision of care using telehealth. So the bottom two pictures are the telehealth stations that we used beginning about 5 years ago. We did use these for a while in our faculty practice, and our College of Nursing has a nurse practitioner-led interdisciplinary team-based clinic on the Near East Side of Columbus that now has a designation of federally qualified health center. To address a need for access to care at one of Ohio State's regional campuses, the Lima campus, we extended our services from Total Health Wellness to the Lima campus, and we began by using these telehealth kiosks. Of course, all that has changed now. Our federally qualified health center has actually changed to delivering care by telehealth using mobile technologies, not using the kiosks. And I do want to give a shout out, and we'll hear more later from Dr. Candy Reinhardt. But as the pandemic began, in 1 week, Total Health and Wellness moved 100% of their visits to telehealth. There's a small picture of a workflow on this slide. It's actually HRSA and HHS through their telehealth resource centers, and I'll give you a link at the end of this presentation, has now published various workflows for primary care and specialty care practices. The workflow that Total Health and Wellness used at the beginning of the pandemic is actually very similar to what HHS has now published. Basically, patients were supported in moving from in-person visits to telehealth visits, and they did it for 100% of their visits. And we'll talk some more about that. You know, basically video visits can be done and have been done through MyChart and UpDocs. There's a note on the slide about Doximity. We primarily use that to have students be able to join video visits. The use of telehealth is to deliver care certainly has provided unique and enhanced opportunities for interdisciplinary as well as intradisciplinary collaboration. All right, so we not only integrated telehealth into the curriculum and into our delivery of care, but we actually moved all of our educational efforts online. And the positive result, now this picture probably looks very familiar to you. You've spent a couple of days and we've spent months now connecting by Zoom. But what we've learned through that is students have really developed a comfort level and a familiarity with telehealth technologies. The challenge, part of our challenge at the College of Nursing, as it's been at the College of Medicine and it's been with students across health sciences, part of our challenge is still incorporating meaningful clinical experiences for our students. Many of whom, again, like I had said, they're clinicians themselves. So one of the programs that we developed, and Carolyn referred to that at the beginning in the introduction, is the Wellness Partner Program. It was developed in collaboration with Trusted Health and their Nurses First company with the Office of the Chief Wellness Officer and the College of Nursing. So what we did with this program is we recognized the problem with clinician burnout and how that was being exacerbated by the pandemic. And what we did was we offered nurses working in COVID-19 hotspots across the country, we offered them a wellness partner. And their wellness partner were the advanced practice nursing graduate students who were enrolled in clinical courses. So nurses were paired with graduate students, and then they met with them 4 to 6 times over a 6 to 8 week time period. So we did this in the summer. One of the pictures on the slide is what COVID-19 hotspots look like during the summer. And during the time that the students met with the practicing nurses, the nurses were provided support for establishing self-care and reaching wellness goals. We had 195 nurses who met with 49 APN students over those 6 to 8 weeks to prioritize wellness and resilience, and the students were able to complete clinical hours during that time frame. Some of the outcomes are listed on the slide. The nurses shared with us, 97.3% of them, that they were actively engaged in self-care and wellness during the program. 94% agreed or strongly agreed that the initiative helped them to improve their well-being. The key was really actually the social connection. And what we realized is in this time of requiring physical distancing, the thing that mattered most is that people had a connection. And so the program has expanded. Our graduate students now are supporting wellness for undergraduate students across Ohio State University, including all extension campuses. We've expanded some of this through the CARES Act. And our university students, as you could well understand, are experiencing higher levels of stress, anxiety, and depressive symptoms. And so our graduate students using Doximity and Zoom connect with university students as well as nurses across the Med Center as well as across the country to provide wellness support. We've gotten a lot of really good feedback about this program. The students feel like they are contributing in a really significant way. They are learning to support wellness and obviously an important clinical skill. The nurses, one of the quotes from the nurses I really found it helpful in understanding the importance of the program for them. I'm going to read this quote to you. Then one of the nurses involved in the Wellness Partner Program shared that she really enjoyed the nurse-to-nurse relationship that developed with her wellness partner, and she looked forward to the weekly meetings. That it made a lot of difference to talk to another clinician who knew firsthand the challenges and stressors of practice. She said, "Great program, thank you." And that was really typical of the kind of feedback that we got through our Wellness Partner Program. So the College of Nursing is implementing telehealth for the students across programs, as well as through clinical experiences at Total Health and Wellness. And so in this last part of what I'm going to talk to you about, we're going to talk a little bit about what we share with them and what we've learned about best practice related to telehealth. Certainly one of the things is that we understand even more so why this area called webside manner or netiquette or etiquette is really an important and developing area of expertise. We've had to really work with students to help them understand how to maybe adjust their communication skills related to telehealth. Certain things that you have to think about. One is eye contact, especially the subtleties of eye contact during a telehealth visit. We teach students to look at the camera, not necessarily the face on the screen, so that they're communicating empathy. And so that, I mean, it's kind of, for some it's an easy skill, for some it's difficult. If their camera's at the top of their screen, they have to learn to look there. If it's on the side of the screen, they have to learn to look there. And most of the time, naturally, what happens is you try to look at the person on the screen, and that doesn't necessarily communicate empathy. Some other things that they've had to learn to do is if they're charting in electronically, or if they're taking notes on a visit and they're looking down, they have to be sure that they tell the person what they're looking at or what they're doing, because it can't always be seen on screen. And the other piece to this is they really do need to learn like what, that something like a coffee cup or a drink could be seen. And so to be sure to keep those things off camera. Prior to the pandemic, for Medicare reimbursement, the originating site for telehealth or the patient location generally had to be a healthcare facility that met rural eligibility requirements with few exceptions. And since then, that has absolutely changed. So we're obviously implementing telehealth for people who are in their homes. And so one of the things that we teach students and that we know now as clinicians is to ask people, are they in a safe location? Are they in a location where they can confidentially share information? And when I look at the pictures on the slide, I think about how we used to talk about like how to set up a patient room. And now we're talking to people who might be outside in their car or in their home or occasionally at a coffee shop, not so often anymore. One of the barriers or considerations to teaching and providing care by telehealth are obviously that the majority of clinicians didn't have telehealth in our educational programs. And so we're learning as our students are learning. And we do have students, when we are in person, learn the hands-on skills of using digital peripherals. And so those are things like a digital stethoscope that, when they listen to a person's heart or lung sounds, if they're using a digital peripheral or digital stethoscope, uses Bluetooth, and then the clinician on the other side can hear those heart and lung sounds. The same with the use of scopes that you see in the top two pictures on this slide. So an oral exam and nasal exam and ear exam can be shown on the screen or to the clinician on the other side of a telehealth screen. But what we've learned now since the pandemic is most of the time, people do not have a nurse or someone with them when they're accessing telehealth. And for the most part, our equipment and use of technology has simply been things like digital thermometer or a scale. A flashlight is helpful so that the patient can actually shine the light so that you can do an exam of their throat. And then we have worked with Medicaid across Ohio in one of our QI initiatives to be sure that individuals who have hypertension have access to blood pressure monitoring ability at home. And so a thermometer, a scale, a blood pressure monitor, and a flashlight tend to be the things that we use most frequently, and not necessarily digital peripherals so much anymore. So the students are having an opportunity to learn telehealth. Certainly their practice will include telehealth as graduates. And so they're doing this through standardized patient exams, and they're doing this through opportunities to join clinicians in telehealth. There are checklists related to telehealth etiquette. What's on the screen is one that we have developed at the College of Nursing. And it basically goes through purposely a visit, an episodic visit, to help our students see that, being purposeful about introducing themselves, verifying consent, maintaining eye contact, maintaining professionalism and etiquette are things that are really important during a telehealth visit. One of the other things that we've learned is that this really does teach our students the importance of taking a good history and the importance of inspection and observation. Old Dominion University did publish a playlist of physical exams and it's on YouTube. They're really fantastic to help students learn what part of physical exams can be implemented using telehealth. But again, mostly learning how to take a great history and learning how to be intentional about inspection and observation are the biggest skills that our students are learning in implementing telehealth. Challenges then, so what are the barriers as clinicians that we are likely to encounter? I would say the first would be technology challenges. Obviously, if you're delivering care by telehealth technologies, the biggest challenge is using the technology. On the bottom of the slide in that far bottom corner, I don't know how well you can see this, but I don't know if you know the story of the boss who turned herself into a potato during a meeting. She couldn't figure out how to turn off that setting. And so during the entire meeting, she looked like a potato. And I bring that up because, oh gosh, our vice dean at a meeting once was telling us this story. And during it, she did the exact same thing. And when the dean arrived to share some serious information, our vice dean during the meeting was a potato. And so we really need to learn to use the technology, because the last thing we want to do is to, try to implement a clinical exam looking like a potato. The other piece to that, though, is we're also trying to teach our patients what to expect, right? And to approach it as the real clinical visit that it is. In terms of financial considerations, most states now do have Medicaid policies related to reimbursement of services provided through live video. It varies across the country what types of services are eligible through state and private insurers. But we do know that this has changed during the pandemic, and this has made a huge difference. The other thing that, I started this with talking about telehealth being, providing care from anywhere to everywhere. And we may get there, but we are not there yet. So I do want to be sure to say that we do have legal considerations in implementing telehealth. And we caution our students as well as clinicians who we are talking to about telehealth that we do not provide care to individuals across state lines if we're not licensed in the state where we are located, as well as where the patient is located. And so there are some interstate compacts, licensure agreements. There are some differences during the pandemic in terms of some states have reciprocity agreements. For the most part, the stance that we take is the provider should be licensed and certified in the state from where they are located, as well as from where the patient is located, with rare exception. Okay, so the other thing that I want to say is this: we don't want to deliver substandard care when using telehealth. We want to meet competencies, standards, and policies. The other thing we want to do is to ensure access, and we don't want to exacerbate health disparities. One large practice during the initial phase of the pandemic looked at the population to whom they were delivering telehealth care, and they looked at, and what they found was significant decreases in the ability of older adults, non-English speaking patients, and for those with Medicare and Medicaid to access how they were delivering telehealth. This was published in the New England Journal of Medicine in May of 2020 with the recommendations that for clinicians and health system leaders to proactively explore potential disparities, to mitigate those disparities through digital literacy and services, and to remove health system barriers and advocate for policies and infrastructure. I know we're going to have a postscript here, and Dr. Candy Reinhardt is going to talk to us about telehealth at Total Health and Wellness. I do know that the staff from Total Health and Wellness reach out to the patient before a telehealth visit, and there's reaching out after a telehealth visit, and there's backup plans for if patients can't access their web conferencing. Okay, a few resources that I want to share that I would recommend. The first is the American Telemedicine Association as a source of information about best practices. The other is the HRSA-funded Center for Connected Health Policy. They are tracking policy information, and they regularly update online state laws and practices, as well as federal legislation and regulation. And then one of the best resources online related to telehealth is the telehealth resource, the telehealth resource centers. They are also under HRSA's Office for Advancement of Telehealth. And generally the webinars, EBP materials, practice toolkits, the etiquette checklist, the PE videos, some of the things that I've shown you that we are implementing at the College of Nursing in our educational programs, and they are actually freely accessed through the telehealth resource centers. Their mission is to foster the use of telehealth technologies and to provide healthcare information and education for providers, especially those who serve rural or medically underserved areas and populations. So they are really fantastic. And the information that you can access online, including the evidence and rationale for practice, are just amazing. So two concluding thoughts that I have. The first is, oh my goodness, the Jetsons were really more accurate than expected, right? between how our home offices, our online classes, our telemedicine, and our video calls look like. And then the second is just a thought about the consideration for using telehealth technologies to support our clinicians and address the mental health crises that we're seeing. We've got a pandemic inside a pandemic in terms of the need for mental health services. So I've got two websites on the slide. The first is a link to the evidence-based policy brief that was developed to address the need for clinician well-being and patient safety. And the second is the link to the National Academy of Medicine's Action Collaborative on Clinician Wellbeing and Resilience. Ohio State College of Medicine, College of Nursing, Emergency Medicine Residency Program, and OSUMC are highlighted as a case study for implementing wellness across health sciences programs. So we are in many ways reimagining the delivery of care, and I hope that just even the discussions you all are having today continues to spark innovation and best practices. So now we're going to be fortunate to hear a postscript from Candy Reinhardt regarding the telehealth initiatives at Total Health and Wellness.
Thank you, Alice. I am located at East Hospital right now, so I have to wear a mask while I'm here. But I'll just start out with describing our clinic. Alice gave a nice overview, but we have been in existence since January of 2013. So it's our 8th anniversary. We're a brainchild of Dean Melnick and Vice Dean Graham from the College of Nursing, who created this nurse-led interprofessional clinic that mission was to care for the underserved. And it became obvious that funding would be required to be able to succeed with that mission, especially with the interprofessional staff. And so we sought to become a federally qualified health center as a co-applicant with OSU Wexner Medical Center. And we were a lookalike for 2 years, and then we achieved recognition as a fully funded FQHC in September of 2019. On our staff, we are nurse practitioner, primary care providers. We also have 3 women's health midwifery providers. We have a pharmacist. We integrated mental health from the beginning, and we have a psych MP and mental health counselor. We have an RN case manager, community health worker who's also an outreach coordinator, social worker. Don't want to leave anybody out. It might come to me later, but that's our team. And we were successful, as Dr. Teal noted, in taking our switching over to telehealth within a week. And I just like to say that the knowledge and the ability to provide telehealth has been there. We did have our Lima campus telehealth with the kiosk setting. We had an RN based at Lima who the NP would direct the exam, and it was all Bluetooth stethoscope. It was really state of the art. And that we provided care to the faculty, staff, and students at OSU Lima. But the problem, again, had knowledge and ability, it was just getting paid for. So the health plan for OSU paid for that, because we can write our own policies, but that there was, it was hard to really get it going because of the lack of pay. So once we were being reimbursed for this, that was really key for what helped it to take off. That's the bottom line, and that was really the missing component. So we did literally in that week totally go virtual. We sent our patient access coordinators and our mental health and our PharmD and dietitian home. They haven't been back yet, or PACs, some helping with scanning and things, but otherwise all those services are being done through telehealth. After a week, we figured out how to have one provider for those things that we needed to see in the clinic. Our midwives just follow the ACOG guidelines for when they had to see the pregnant patient in the clinic and what we could do telehealth. And with Medicaid, especially paying for that first visit for to establish and paying for that, where before that was a problem. Telehealth wasn't considered for a new patient. That was real key, that they could even actually do a better history and documentation and things with that telehealth visit than they could actually in the clinic. So lots and lots of things. We switched all of our MAs over to Doximity for phones so they could mask their phone numbers when they called patients. And we went initially from MyChart was our video platform, and then telephone, and then we went to UpDocs. And later on, we added Doximity. And we added Doximity because it was the first that we could add our students to, because as quick as we figured out how to provide patient care, we weren't as quick as being able to figure out how we were going to educate our advanced practice nurses especially. But as an interprofessional clinic, every single one of our interprofessional health sciences has a health sciences student. So it wasn't just nursing and advanced practice nursing students, it was all students that we needed to figure out a platform for. So originally that was Doximity, that we were able to have a 3-party platform. Now UpDocs has that, and we've come back to using UpDocs primarily with our patients. There was a time that we felt, well, we could respond to the need, especially for the surge, and that there were family practice providers that were going to need to be providing inpatient care. So we moved ourselves to Outpatient East, formerly known as CarePoint East, and covered for those providers, did our telehealth from there, saw patients that needed to be seen so that they could quarantine appropriately, work in the hospital appropriately. And so it allowed a flexibility there that was wonderful. Even now, we are doing probably 80% of our visits still virtually. Our MAs room the patient virtually, look at meds, get vital signs, have the patient reported data, or we utilize our students to actually have that experience of talking with the patient and to document the HPI, get the medications, get them prepared, any new concerns and things. Lots of positives. When you look at what the positives are in this, I mentioned the flexibility. Our no-show rate has plummeted. Many of our patients, I should say many, but transportation was a big problem. And you'd ask a patient, why didn't you come to your appointment? Why did you go to the emergency department later in the day? They didn't have a ride during the time for their appointment. And so our no-show rate hung out between 25 and 30%. For the most part, and it's 10 to 15% now. It still kind of blows my mind why you have a no-show when you're a virtual visit, but still do. And I think one of the other great positives is just caring for people while they're isolated. And Alice talked about this a little bit. We've been able to do some great outreach. We've had our APRN students as part of their clinical time, and in coordination with our ACO here at Ohio State to do some outreach, just to do a COVID check, just to go through and to teach about the isolation, to check on people. We used it with that initial outreach, looked at patients who had congestive heart failure, COPD, and diabetes, just to see how they were doing with that. But one of the main outcomes of that is just really looking at the social determinants of health, and somebody saying, do you have enough food? Do you have someone that can go out? Do you have a mask? Do you have all these things that you need? And just being able to talk with our patients, it was wonderful. So we started out with ACO patients, so 65 and over, and then we we went and we started doing diabetes management and hypertension and reaching out to all patients with that. And again, our social worker had a lot of tasks after many of the phone calls, just because we picked up on so many things. Just making that connection and them feeling like they could tell us those things. Another big positive is that we've only had 3 staff get sick, and that's, you know, with our team, that's real important. That was our goal, not only to keep patients from getting ill when they came in, but also to keep our staff healthy. And you know, that was community acquired. It wasn't in the clinic, but to be able to not put anyone at risk was real important. We believe that we'll be doing this for the long haul now, especially when probably 55% of our patients are Medicaid and it continues to be paid for. Our space for us, we're pretty landlocked where we are, and space, adding new services and providers was limited by space. And now being able to just kind of juggle our schedules and be able to utilize rooms a little bit better, I think we'll be able to add providers and services that we wouldn't have been able to before, for sure. One worry I have is that we'll never see our patients again. They've enjoyed this quite a bit. We tease that they're not going to come back, and they'll say, "Well, I like this. Can we keep doing this?" Or, I had a practice in Springfield where I still live, and many of my patients followed, and it's so nice to not have to run them in, and be able to have the time to talk to them. And it's nice to visit people in their home. It's enjoyable to see their house, and it feels you feel closer to them. Although I do sometimes just physically just long to see a patient in person in that 3D. It's still we've been able to make this work and have the relationships. And I got lots of funny stories about people not being dressed and see more than I wanted to see at a visit, but I'll write that book later. It's pretty hysterical. So, but I think that's about what I wanted to say, and we're going to go with any questions now, Alice.
I don't see any in the chat or in the Q&A, but I was wondering, this is great presentations. Do you have any community-based clinical trials or clinical research visits happening at your clinic?
We have a,
I know you're doing nursing research, various things like that, but I didn't know if the med center that are doing clinical research or working with you guys.
We just finished a study right before COVID that was looking at how to assess social determinants of health, just a quick form that allowed just questions that we were able to study and look at. It was created by 2 RNs, leadership in the health department. And see, presently we have our, you mentioned our nursing study. So we have our nursing research with our pregnant ladies in depression going on through the College of Nursing. And I think the others have concluded is what's going on now.
Mm-hmm. I know that many of us have even experienced the telehealth ourselves as patients, as things have cropped along, and it just makes perfect sense now, and I can see it being useful for caregivers as well.
Patients used to ask, why do I have to come in? I know that's what I have. And you would feel bad about making them run in because you knew what they had too. But, the bottom line was you weren't going to get paid for the visit, and you're giving away your time and talents and expertise, but now we don't have to give it away. We can, and if if it fails that first visit, as far as treating the differential, or, they don't get better, they always, they know that they can come in and be seen. Just
Yeah.
play it by ear.
Absolutely. Well, I know there's certain populations that just quit going to the doctor, and you're kind of on your own, thinking about Parkinson's patients. It's too arduous, to get even in the car. And so they tend to stop their visits completely toward the last stages of their disease, which is unfortunate. So this is great.
We do have an aging at home. I didn't mention that. We do have one of our providers does go to the home. 15, 20 patients that we do that for, just so they can stay home with their families and things. So yeah, that works out too.
Great.
We're able to do our hospital follow-ups in a very timely manner, or even your ED follow-ups. And, before Medicaid requires that 48, 72 hours. And now we can talk to them within that, they need that time to get a ride, and we can see them through telehealth. And I don't know if anybody's looking at it, but I'm sure it's decreasing the returns to the emergency department.
Right. Well, it is. We have a question. Do most of the telepatients have access to computers, and then more importantly, to Wi-Fi, internet access?
I think that Candy, you're going to find the same that we do. Most of the time, people are using a smartphone more than a laptop or a computer or anything. They're using the smartphone, and most have. I mean, we do have to watch, some people still on a pay-for-minutes service, right? But most people are using their smartphone to access the visit.
And it's made it more involved because they proudly give you their vital signs, their blood pressure, and then they'll say, my pulse is, I took my temperature, and all these things. And we've had more people sign up with My Chart to be more active in their care too, where before it was like, oh, I don't want to do that. They had some reservations, and now, and we use those terms. I know when I talk to my patients and say, I need you to be doing these things since I can't be seeing you so often, so I give them a job, and they enjoy that part now. They do feel more in charge of their healthcare, and rather me being in charge
Empowered.
and empowered. Yeah, it really has made a difference.
That's great. Well, thank you very much. I think we have do we have any additional questions before we go on to the poster session? Tiffany? There she is.
Hi everybody. I thought Guy was going to do the poster section, but I can do it really quickly.
Oh, here he is.
Oh yes, sorry, Tiffany. I didn't know if you were going. I can do it. Sorry. Yeah. So thank you everybody, and the poster sessions. Just a few words about it. If you go to the top menu, there's poster sessions right there in the middle. So you want to click on that, and then it'll take you to the exhibitor list, and then you'll want to click on the poster that you're interested in, and that'll take you to a screen where you can view the poster. And then also, if you scroll down underneath the presenter's name, there should be a little box, and when the presenter is present, it should say office hours open, and you can click on that, and it'll take you to a breakout Zoom room where you can ask the presenter questions about the poster. So we got a pretty exciting lineup of posters that span the clinical and translational spectrum, including artificial intelligence, machine learning, and rural health, and COVID-19. So please take the opportunity to go and view the posters and interact with the presenters. Thank you very much.
I'm trying to figure out on this view that I'm logged into whether I can even see.
You won't. You have to go into the web page.
Yes, you have to go back to the actual conference platform for the speaker.
Oh, can Mills James please put that link in, because Not sure I can do that. I'd have to go find it.
I can probably do it myself.
I am putting it in the chat. Yep. Sorry, so that's Karen.
Thank you.